Kia ora koutou. Welcome to today's webinar on driving supply chain efficiencies through digital transformation. I'm Rebecca Macbeth. I'm the media editor at HINS, and I'll be your facilitator today. I'd like to thank Workday for sponsoring this webinar. So we have a really fantastic lineup of speakers today. I'm going to ask each panelist to just briefly introduce themselves. So joining me today, we have Eric Wallerius. Kia ora, Eric.
Hello, everyone. My name is Eric Valerius, and I'm the Chief Supply Chain Officer from UW Medicine in Seattle, Washington, and look forward to joining you all today.
Thank you, Eric. And we have Ashley Gross.
Good afternoon. My name is Ashley Gross, and I'm the Executive Director of Supply Chain at Roswell Park Comprehensive Cancer Center in Buffalo, New York.
Kia ora. Thank you, Ashley. And Keith Lohkamp.
Hello, I'm Keith Lohkamp, Vice President of Supply Chain Management for Healthcare at Workday, with responsibility for the supply chain management products there.
And Esther Monks.
Kia ora, Rebecca, and thank you so much for having us today. My name is Esther Monks. I'm an industry advisor with Workday, supporting across the Asia Pacific and Japan region.
Thank you, Esther. So first we're going to have presentations from Eric and Ashley, and then Keith and Esther will join us for the Q&A, where I'll open up the floor for questions. So do please keep those coming in at any time using the three dots button and the Ask a Question button. So first we have Eric. Take it away.
Thank you, Rebecca. I have a few slides that I prepared here. So being a visual person, I wanted to step through a little bit of background of our journey that we've had here at UW Medicine. So first step in, who we are, a health system in the Seattle, Washington area. A few slides on our supply chain evolution and the journey we've been on, and then dive a bit more into what we call an ERP, or Enterprise Resource Planning, is our acronym for our healthcare supply chain system, and where we went from and where we have moved to, and then where we're focusing this year and next year. So diving right into it, UW Medicine, as you see on the map there, we're headquartered in Seattle, Washington, and support Washington State along with what we call the WWAMI region, which is Wyoming, Alaska, Montana, and Idaho. We have a bunch of buildings, as you see, reflective on those pictures, a fixed wing and rotary aircraft for urgent transport of patients, 3 locations, roughly 1,600 beds. You see just shy of 30,000 employees, a bunch of births, bunch of procedures happen throughout the year, and then roughly 1.3 billion in annual supply chain spend that our team oversees. A bit more, I thought it would be interesting for the audience here of how we're structured here. My role as a Chief Supply Chain Officer on this org chart, and I won't go into great depth, but at a high level, we roll up under the Chief Financial Officer for our health system. And then as you see here, we have 3 key teams. On the left side, we have a strategic sourcing value analysis team, a materials and logistics team that handles all the deliveries and movement of our supplies. And then we have a informatics and strategy team that does all of our reporting, dashboards, visualizations, and emergency planning and preparedness. A bit more about our background. We spent a lot of time over the last few years of how we show up each day in our organization, and developed a vision statement to be the most trusted partner for our clinical and support services teams. So that's something that we live and breathe. We have a handful of recognitions. I'm not going to go through each one of these, but there's things that we're very proud of that we've been able to achieve around sustainability, around our automation and efficiency, our ranking in our group purchasing organization, or GPO as we call it, around price performance to ensure we get the best pricing possible. And then another component that we're very proud of is around sustainability of reusing single device products. On the right side is the grid of the savings also that we have really, through a lot of hard work, achieved over the last number of years of excess of 100 million in annual savings that we've been able to reduce to our health systems and our organization. A bit I thought would be interesting for the audience around our maturity around our value analysis program. So we have spent a lot of time and energy evolving our clinical-led decision-making for the products that we select. And so we have over 80 physicians and clinicians with a reinvestment program that they get 10% of the savings into these service lines that they achieved. And so that 110 million, over 10 million of that has been put back into these service lines. And you can see the evolution of that we've been able to achieve with not supply chain leading discussions, but our clinicians and physicians. How that is structured, just getting a bit more granular into that structure, is we have 8 different core groups, starting with our GI, endo, going into our interventional radiology and vascular, cardiology, orthopedics, spine, surgery, patient care, and CV and cardiothoracic. So these are the groups that are being led by these physicians, and the data that we have that is helping feed these decisions is coming out of our ERP system. And as I touch on in subsequent slides, the investments we've made in having actionable reporting data and centralized data has been a real game changer in these groups to being able to make decisions and standardization efforts. And then below that, we have supply chain portfolio managers that are leading and facilitating all of these discussions that are being done with our clinicians. As we continue, I thought it was also worth highlighting, we mirrored the success of our value analysis clinical work with that then of purchase services. So again, connection back to our ERP and our data. It's something that, at least in the United States, we've struggled historically, and my organization is no different, and really grasping the purchase services. And you see a long laundry list of areas that we focus underneath here to make meaningful impact and cost savings and standardization efforts around this work. So we have a similar infrastructure set up here for the purchase services work or non-clinical products that we've aligned. And then again, using our data that we have across our ERP to help drive the various discussions and decision-making that are happening across these 5 core groups. Moving right along, I wanted to then dive into where do we start this journey of our ERP or our movement to predating our modern ERP system. So I think, like many of our counterparts here in the United States, we had a on-prem or locally hosted, and full disclaimer, that was not actually our server room, but that was, I think, an accurate visualization of where we moved from. It was very dated, it was very antiquated, systems that we hosted locally here in supply chain. It was separate systems that we had in supply chain, which was different than what our HR system was. Finance was tied in, but it was separate instances. So one hospital, we literally had one login to access what products were being used at that hospital. And we need to contrast that to another hospital. We had to log into a separate system, separate passwords, separate usernames into that other system just to see products and comparing and contrasting the two. We often waited until it was absolutely necessary to do updates for our software, which created a level of risk in itself. But it was just how we showed up and said if it was absolutely necessary, the vendor was going to stop supporting this software, that's the time when we had to do the update. Also worth noting is our health system is part of a larger University of Washington health system, or excuse me, academic medical teaching students and various research that is happening. And so they themselves had their own ERP and legacy financial system that was built in the 1970s. So going on 40-plus-year-old system that they realized that they had to update. In addition to over 800 side systems that we documented as part of this process that were all supporting this central antiquated old system with various bolt-ons that did certain features that the main system didn't. So needless to say, it was a hodgepodge of various systems cobbled together through the years, written in a programming code that very few people actually knew because they were retiring. And I think that was part of the risk and catalyst to make this move was, we had an increasing likelihood year after year of not being able to effectively manage and support the system, given so few people actually knew the proper coding around it. So that's what we lived for the vast majority of my time in my career and in my role. But pleased to share, July of 23, we went live on our new system, and it's a modern ERP. We were super excited for. In full transparency, we had heard horror stories of others going ahead of us to new systems and all the challenges associated with that and the heartache and the data integrity. It went way better than expected for us. And not to say there was our fair share of speed bump and hiccups, but from the medicine standpoint, it went extremely well. Again, way better than we expected. That said, it was a 5-year journey. And so we went live July of 23. We started these planning works half a decade prior till we actually went live, including 2 delays because we recognized we were not ready in partnership with the university. We have a new governance structure, which I'm really excited about, with supply chain at the table, helping shape and prioritize the ongoing investments and optimization that is needed for our new system. We have a single instance, so no more separate logon for each of the hospitals. And not only that, we have one instance with the academy or the university, as we call it, and with medicine. So we have visibility across products for the whole university, including medicine and the academic side, in addition to sharing of contracts, which has been a great efficiency. From an update standpoint, as I touched on our old system, we did it at the least possible, delayed it as long as we could. Now we get them, whether we like them or not, twice a year. And there's an option where there is required functionality in addition to optional functionality. And that's what we've been investing resources in, making sure we maximize this investment that we've made and taking the optional functionality that we see value in, that's going to improve our efficiency and the work that we do. Another big win is around the online community that our team is very active in. So there's functionality that we see as needed. And so we put this in these online communities where peers can vote and give us kudos or thumbs up where they similarly share in that frustration or that need. And so it's great where you have this voice of these collective peers of directing these organizations for needed improvements. We've been successful in decommissioning many, but not all of those 800 systems that I touched on earlier. I'm pleased to say that our team on supply chain, we've decommissioned all of ours, but there is numerous others that are still in the works that are mapping out when that actually makes sense. And you can imagine the efficiencies gained of shrinking that even in half. But our goal is much more than that, to less than 100 of those staying around. And I think the key thing is that last bullet around the vastly improved data and reporting capabilities. I touched on that a bit before, but wanted to emphasize we had a recent, and I believe it may have been worldwide, the impact of the IV solutions that happened on the U.S. healthcare industry here recently due to Hurricane Helene. That really caused significant devastation in the southeast part of our country. But with our improved reporting capabilities as a result of our system, we had visibility across all of our sites of care that allowed us to way more timely than we ever could have imagined during our COVID days to report usage, report real-time consumption, that allowed us to manage this such more effectively that we did not have to delay any patient care or impact patient care or procedures as a result of that. And I think the other point noted there is around the visibility of we call it rec to pay, or full visibility of the requisition to the payment. We did not have that previously, and now having that visibility in the whole process has been extremely valuable for our organization. Moving on, just wrapping up on more of kind of a global of what our organization and specifically in supply chain has been focusing on. We just wrapped up our annual supply chain retreat here in the end of last calendar year. And we've accomplished, I think, 7 very big priorities as noted here. 2 were around our ERP, as highlighted in the middle there was the expansion and optimization that we see is going to continue for forever. It's in perpetuity. And around the contract migration. So that was moving all of our contracts that we had in separate databases into a single repository that aligns with our ERP. We've seen significant value and excitement around that. I did want to take just a quick shout out to recognizing another part that I'm really excited about, and that's around the expansion of our supply chain quality program. So not necessarily related to our ERP efforts, but we have built in our own internal auditing within supply chain. And granted, some of that is on our work on our ERP, but this has been a significant investment that we've made to ensure that what we do and the process improvements that we make as part of our ERP, but beyond that, around job aids for our staff, around our competencies, around regulatory requirements, that we're actually doing that. So it's not our internal audit team, it's our own team within supply chain that are doing these audits. That is something that is another accomplishment that I'm really proud of. In conclusion, I just wanted to highlight where are we going this calendar year and beyond. So we have a project management focus that we have along with our strategic plan in supply chain that prioritizes the work that we do. We identified on our retreat 55 priorities going into this calendar year of 25 around those 6 domains that I've highlighted there, and each of those projects noted down there. A large part of these are around our technical system and cost reduction, process standardization, all relevant around this digital transformation that we continue to prioritize. We recognize the value that this is providing. Having a modern ERP system is providing significant value, and it's one that I think our team has touched on for since the start of this work. It's a marathon, not a sprint. And it's an analogy that I continue to remind myself that the work that you do and the investment that you make, not just into our ERP system, but the work that we do is critical in recognizing that you only have so much time in any given day. And if you prioritize that work, that's going to ensure that you stay focused on what is the key and the most pressing priorities. So that was my presentation. I'm going to, I think, hand it back to you, Rebecca.
Great. Thank you so much, Eric. Really fascinating. I'm sure our Kiwi viewers will recognize some similarities in the pre-go live state that you described there. So hopefully that sparked some questions. Remember to keep those coming in using the 3 dots button in the bottom right-hand corner of your player. Select Ask a Question. And if you've joined a little bit late and just want to see some information about the speaker panel, just select Info and you'll see that there. So next we are going to hear from Ashley. Thanks.
Thank you, Rebecca. Next, I'm going to talk about Roswell Park's ERP transformation journey in supply chain. So Roswell Park is a hospital and research organization where we do have 1 main hospital and 3 hubs in the Buffalo region that support some ambulatory clinics. Roswell was founded in 1898 and has had a National Cancer Institute designation since 1974. We have 157 beds, and in fiscal year 24 had 409 funded research projects. And Roswell is 4,200 employees, and our overall support is Roswell really had patients come in from 44 states, one foreign country, as well as 2 U.S. territories. Next, I'm going to talk about my role a little bit as the Executive Director of Supply Chain. So I really am responsible for a team of operations analysts that support our overall systems, content management, and reporting. Also oversee the distribution, receive, and email services team, our perioperative materials management team, our buyers, and I serve as our Workday program manager for a tier 1 governance structure. So our journey started a little bit earlier, where I joined Roswell in 2018, and shortly after joining Roswell, I became the supply chain lead for our transformation into a single ERP system for supply chain, finance, and human resources. As a lead, I really was responsible for the overall design and implementation of procurement, suppliers, as well as inventory. And in terms of those responsibilities, it was anything from configuration, security, testing, reporting, change management, as well as training our overall end users. So we did go live in January 2021, Big Bang implementation, where all 3 functional areas went live at the same time. So it was really in the middle of COVID that we were going live. And then more recently, we did bring up Workday Strategic Sourcing in 2024 to support the project initiation to the contract executions stage, whereas our existing structure was more so from contract execution to more so the payment side of things. So in terms of our overall implementation, there were really 5 priorities that I was focused on. One was really transformation to best-in-class supply chain, as well as using best practices and procedures. Secondly, it was increasing our automation and use of mobile technology. Third, it was real-time reporting with improved transparency based off of quality data inputs. 4 was elimination of paper. We were living in a very heavy paper world and needed to get out of it. And 5 was really having that buy-in from our stakeholders. So it was really getting them involved at the time of implementation. So next, I'm going to jump into supply chain as well as procurement. Some of our areas of focus within in both areas, and how we're using the Workday system today to continue to support our overall transformation. So one is really partnering with clinical on our PAR processes that we have set up on clinical and ambulatory units for critical and routine supplies. For the overall setup of these PAR locations and using the technology, we really set up a PAR optimization dashboard that pulled in the lead time, average daily usage, and target days on hand we wanted to really determine what our PAR level should be. And then really based off of our conversations with clinical, we could adjust up or down from that system indicated level. And it was really working with them to develop a core product listing that regardless of what floor an inpatient nurse was on, so if they floated within our house, the same product was in the same location on all of the carts that we stocked, which really helped with that float in or transition to find products more quicker. And then it was really using the dashboard, the Workday, and creating a custom dashboard for PAR optimization to manage that process. Next was really the from COVID as well as Baxter IV, the situation recently in the US, how we really managed or were prepared for pandemics and natural disasters. So similar to Eric, we were really able to use Workday and develop reports that really gave us transparency to usage and how many days inventory on hand we had. From that, we could really proactively work with our clinicians and determine how we needed to adjust product on floors or if we needed to pull product back to ensure we didn't hit stockouts when there were allocations and limited supplies available. And then it was really monitoring case schedules as well to determine based off of cases that were scheduled in the upcoming weeks if we were going to have any critical issues that we needed to get ahead of. And really with this, we were really able to develop a robust system and really have that clinical partnership where it was, we gained trust early on during COVID, and it's continuing to build on that partnership day in and day out with them. And really, the other thing we encountered after we went live is we went live with an in-house warehouse and switched to a logical unit of measure program with a med-surg distributor. And based off of what we learned from COVID, we really identified the need to set up safety stock items in-house through identification of what is critical that we cannot run out of at any time. And so we have that additional buffer outside of our distributor as well as what's distributed on clinical units. And then mobile technology, we really optimize mobile technology, using it from receive in functions, attach and pack and slips, capture and signature delivery, par counts, inventory counts, where we truly are fully mobile today, whereas in our prior state, we didn't really leverage mobile as much as we should have. On the procurement side, one of the key initiatives we did at Go Live was develop a procurement dashboard that our buyers could work off of. What that really offered was an experience for them that when a requisition was entered, a buyer could track it based off of cost centers that they were assigned or departments and track it from sourcing to a purchase order acknowledgement to purchase order to acknowledgement, and then acknowledgement to match exception if one existed in the system. So that really gave transparency to the overall process, what were potential issues, and then we really worked in open PO lines as well to ensure our buyers were using good practice and managing open PO lines, working with their departments and key stakeholders to ensure that we were up to date on everything. And then it was really working with them on the perfect order, how we could reduce touch points in the system so that when a requisition was entered, if it was non-catalog, that they sourced it, they had to acknowledge it. And from there, they really shouldn't have to touch it again unless the product is on back order. And then catalog items, same concept, catalog item to acknowledgement. And same thing, really, if we are maintaining a good item master, shouldn't have to touch the item again. So it's fewer but smarter touch points in the system. And then from a technology perspective, we really wanted to re-implement our EDI platform, which we successfully did to maximize suppliers that we transacted with. As part of that, we stood up an order management function that really switched order management over to our EDI partner, gave time back to the buyers where they were only working exceptions at the acknowledgement stage in Workday. And through the time we were able to give back, it was really refocusing on more value-added activities, such as negotiating prices for non-contracted goods. And then project initiation to contract execution, that's really the more recent one we've been focusing on with Workday Strategic Sourcing. So we really did stand that up for product or value analysis, as well as projects that are initiated to the point that they're managed or executed for contracts. So it's offered a lot of transparency that didn't exist before, where stakeholders can truly see where items are in the system today. So in summary with all of this, I really recommend building the processes you want, which is not necessarily what you have today. Be forward thinking. It takes more time to do it, but it's worth doing it right instead of having to go back and fix items later. And it's ensuring that good quality data is entered into the system to have good quality reporting and better decision making. It's a key component of involving key stakeholders in the process, where we brought in clinical leadership as well as research leadership early in the process, actually got them in the system to test it end to end, to look for true gaps in the system or where we had to further develop the technology for them to make it an easier transition and eliminate the paper waste that we had. And then it's continuous improvements within supply chain. For us, it's continuous improvements through education, processes, as well as technology. We are always looking at how we can eliminate that waste and refocus on value added activities so that everybody has a list of items that need to be accomplished. How can we get to those more value added items that will give time or give money back to the organization? And then the final component, really in terms of transformation, is the ERP system should grow with you. We did go live in January 2021. And as part of the release management to ensure we didn't have a stagnant system like our prior system, it's really been implement. So we heavily adopt all of the release items that are available to ensure we're at the forefront of the technology. With that being said, I'll turn it back to you, Rebecca.
Excellent. Thank you so much, Ashley. And I think that learning about, putting in place the processes you want rather than digitizing what you already have is a very good lesson for all digital transformation projects, actually. So great. We'll move into the Q&A now. So I'll invite Esther and Keith to join us on the panel. And do remember that you can ask questions using the 3 dots button in the bottom right of the player and select Ask a Question. So first we're going to go, I think we might get you to start on this one, Keith, if that's okay. Just generally talking about the global trends in supply chain that you're seeing that health organizations are having to respond to.
Yeah, there's a numerous set of trends that all healthcare providers are really facing today. And frankly, Ashley and Eric touched on one key one is ongoing potential supply disruptions. And that could be because of natural disasters, but it could also be shortages in raw material, difficulty in getting shipments from other countries to come in time. So that's a big challenge in terms of managing that part of the resiliency of the supply chain. We're also seeing rising costs across the board, and that could be because of increases in materials, increases in transportation costs, potential of tariffs coming up. But it could also be new innovations in terms of products. So a lot of the innovative medical devices or pharmaceuticals are ended up being extremely expensive, and those are driving up costs as well. And that's sort of coupled with often rising labor costs as well. So we're seeing those as key trends that supply chain organizations are facing. And then frankly, one that's both a challenge but also a real opportunity is changing expectations of patients. So there's a lot of different expectations in terms of where you're going to receive care, whether that's in a clinic, whether that's going to be through telehealth. That creates additional challenges for supply chain leaders just to support the organization as they start innovating in how they deliver care.
Did you want to jump in there, Eric or Ashley, to talk about any other trends that you're seeing? Was the COVID pandemic something that really highlighted, I guess, this to the wider organization as well in terms of supply chain and what the potential risks and challenges might be?
Yeah, I'm happy to add to that. And, what Keith was touching on really resonates with me. COVID, I can't believe it's been 5 years, but since we had our first patient was almost to the date 5 years ago. And we've gotten really good at managing product disruptions. And I would say, at least for our organization, part of that, we had the luxury where we would have reliance on our distributor, as Ashley touched on, and we had a just-in-time or low unit of measure mentality, and we ordered one day and the stuff came the next day. And I think as many of us could appreciate on this call, there was a long period of time, at least for our organization, that we couldn't rely on that. And then the peak of the pandemic and product shortages and disruptions that now have continued. I know for our organization, on any given day, there is 350 to 400 items that are either back ordered or on allocation, meaning that we can't get the volume that we need. And so as a result, as Keith touched on, we've had to bring in safety stock. And as Ashley, I think, has also had to do, that's the reality that we face these days. And we can't let our clinicians down. I know our organization feels very strongly, and our industry of healthcare supply chain is they can't do their job if we don't do ours and making sure they have the product and supplies that they need. So that means we have to have our crystal ball and plan and look at our demand, look at our forecasting, and frankly anticipate what may be happening and have a cushion of those products that are at risk or disruptive to mitigate that happening.
Great. And Esther, could you just tell us a little about the New Zealand and Australian healthcare provider market and whether there's any unique supply chain challenges here?
Yeah, thanks, Rebecca. I think, as Keith mentioned, with the global trends, all of those, replicate across Aotearoa and Australia. I think the thing that gets exacerbated when you're so far away from a lot of the supply chain hubs is that geographical remoteness and the time it takes to get some of those supplies to our shores, and then not just into the major cities, but then out to, the regional areas of the country. And especially when we think about, the health direction to provide care closer to home. Keith mentioned that as well, through telehealth and out to the regions, to First Nations and Maori cultures, and making sure that people are really accessing the care where they need it. I think the other thing as well, we're so fortunate across both of our geographies, across Australia and New Zealand, to have fantastic access to public health. What that also means, though, is that you're part of a bigger machinery of government that is competing for investment into various constituent needs, and so that investment into what's traditionally seen as back office, and and I think historically we haven't necessarily been able to articulate the value, as Eric and Ashley have done today, around really investing in that visibility, that partnership with clinicians to make sure we have the right supplies in the right places to provide the best level of care. Hasn't necessarily been valued in the past, and so I think what we're seeing is really a pull mentality to digital transformation, where we're seeing a lot of systems end of life. In Australia, I've still talked to organisations that are using Excel to manage supply chain inventory in some organisations, and so that really puts that the ability to have the right inventory and consumables in the right place at risk when you don't have that visibility to be able to respond to things like the IV fluid shortage and things like that. So I think those are probably some of the more localized areas that we're seeing, but I think certainly we're at the right tipping point now in with lots of eyes around data and digital transformation to look at how we find financially sustainable ways to move forward. And supply chain, is such an important area that we can look to find those efficiencies.
Thank you, Esther. Yeah, I said before, Eric, that I think viewers would have recognised the hodgepodge situation that you described. And New Zealand obviously recently went through a centralisation from 20 DHBs to one organisation. I'm just wondering, when you have that many systems and that much going on that you don't have transparency on, where did you sort of start, and did you build momentum over time that built up confidence that then allowed the program to grow? Because I'm sure that's what a lot of people are thinking now, where to start.
Yeah, I think that's a fair point. We did a spaghetti diagram of all these 800 systems, and it couldn't fit on one paper, and it was expanded into this wall essentially, and recognizing if we move to modern ERP system, which one would this all be able to be replaced? And it was too bad I don't have like a photo of that, because it's a very powerful visual to see what a modern system can do for an organization that has all these over the years and decades added on this system because we need that unique functionality, and we're going to bolt on this system over here because that does that, but it does a little better than this one over here. And it just decade after decade, they grew and grew and grew. And as you can imagine, trying to manage all of those, maintain all of those, update those security patches, the risks. So this one's broken or it's down, but this one's working, so we have to move it over here. It was a mess, frankly. So for us to streamline that was a huge improvement, I think. But recognizing there is a cost to that. Modern ERPs are not inexpensive. I think you also have to understand, the system, at least our organization was going from, was fully depreciated. A lot of it was homegrown. But there is a cost to maintain and support those, and the risk associated again with those not being fully reliable or functional. There was a statement that resonates with me, and it was our university president said it early on when we started that 5-year journey. I guess I don't necessarily agree with it, but when we kicked off this project, she said these systems are kind of like underwear and socks. And if you have old underwear, and if you have old socks, people don't necessarily see them, but they're there. If you don't have it, and so again, our team, our supply chain, this is I would say it's our Bible. We use our system day in and day out. We manage our inventory. So I don't think we're the typical user, but I think she was resonating to the average person in our university that doesn't see that it's kind of behind the scenes, but it's so critical and so vital. Again, the analogy stuck with me. I'm like, yeah, you wouldn't go out without underwear and socks. You wouldn't go out with having a modern ERP system, I think is the analogy that I'm trying to articulate.
Yeah, that's a very good analogy. Again, you could transport that to other digital systems which are propping up the health system, I think. Did you have something to add there, Ashley?
Yeah, absolutely. I think in terms of that, for us, like some of the concerns were, are we transforming too much too fast based off of where we were, and the fact that not much was adopted prior. To give you an example of that, when we looked at like supply chain overall, in our prior system, we actually were in a state where 60% of the requisitions that procurement received were on paper with department signatures on paper, and then the buyers entered those into Workday. And so there were questions about something as simple as bringing up requisition in 100% in Workday in terms of should we roll it out in phases versus having the organization take it all on at once. And with something like that, it was more so we cannot take the risk of starting with paper and then trying to get those departments away from paper later. So it was really doing that conversion at go live with the proper training classes and education, and given resources that could help facilitate that initial transaction to get some of those users over the learning curve. And so in the end, with something like that, we were successful in converting and were able to overcome that organizational concern just because we did prepare for it and were ready for what it meant for us.
Right, and you mentioned, Eric, about this scheme where 10% of savings were reinvested in those clinical teams. I was quite interested in that. That must have been, I guess, quite a motivation. And just if you can expand a bit on how you were able to take cost savings and reinvest in delivering better care.
Yeah, so that as I touched on spans across all of our value analysis efforts. And it was really a motivation to get our clinicians and physicians to take an active role in the contract and vendor negotiations and discussions, and a commitment to review their utilization. And as we're evolving to per our maturity around our outcomes and quality components. So it was, I guess, a carrot, we call it, to give motivation to say your time is justified here, because acknowledging that that's time away from patient care and revenue generating efforts for themselves and for our organization. So we initially started as a 5%, and they kind of scoffed at that and said, that's not going to be worth our time. Let's do 15%. And lo and behold, we landed on 10%. And, it's not a huge amount of the overall savings, but if you look at what we've been able to achieve, 110 million over the last number of years, as I said earlier, that does, transfer into a material amount. We have guardrails around what that could be used for. One of our surgeons said, I want to use that on scotch and cigars. And safe to say that that is not allowable expenses. It's around education, it's around marketing. So we have a very specific criteria that then goes to the department chair and the core group chair for final approval before it goes to an oversight committee. So we have many layers to ensure that the scotch or the cigar requests are denied before even getting to the first step. But it really has shifted. They are very engaged now, where previously we had like ad hoc physician champions on a specific initiative or project. Now they are running these groups where we facilitate them. And it's been a big factor. I wouldn't say it's the only. I'd like to think people are generally wanting to reduce cost and improve efficiency, but it's certainly been a effective carrot, as we call it, to motivate them to push a little harder than they normally would.
Yeah, I mean, those themes of driving efficiency and sort of getting decisions in the hands of clinicians really chime with a lot of the what's being talked about in New Zealand at the moment. Ashley, how did you work? You did touch on it, but how did you involve clinicians in making decisions about supply chain? What was your approach?
So in terms of our ERP implementation, it was involving them early in the process in our design, where we started with clinical leadership, and then at our end-to-end testing actually brought in the more frequent requisitioners from different clinical departments to go through and actually step through a requisition and ask questions or identify potential gaps in the solution that we needed to address. And so that was really powerful for us in terms of involving them in that process. Outside of that, it's our product review committee where they're really involved in making decisions day in, day out, where we do meet bi-weekly for product review. And then as we look at our supply chain inputs, how we manage PAR locations, trying to reduce items that the departments are having to order direct that are routine items that we can fit into the PAR model, taking that on to give time back for patient care or research. And really it's identifying those pockets where we're underserving today to stand up new PAR locations that we can take on those additional services as well. So it's constant conversations with them, having that constant dialogue in terms of how we can help them and identifying opportunities to partner together.
Thank you. And everyone sort of talked about a little bit about the resiliency. Keith, maybe you could answer this one. It's just about, how does greater resiliency in the supply chain help organizations to be better prepared for what we know is becoming more apparent, weather events and pandemics and things like that?
Yeah, I mean, I think both our panelists spoke to how they were able to become more resilient by really having better visibility into what was happening within their supply chain, so better able to react, better able to adjust their their inventory. And I think some of it also now, after kind of going through the experience of COVID and multiple disruptions, now getting ahead of it and starting to really plan, whether it's having safety stock, but also thinking about, do I have substitutes already set up, those alternate suppliers? Do I have a playbook for those critical items? Not just how do I order them or manage the inventory, but if I have to switch to a new product, what's the impact on training of the staff and communication of those replacement items as well? I think the new thing that's really kind of coming up is the risk of cyber attacks and the impact it has on health systems. I think what they're saying in the US is that healthcare is the number one target of cyber attacks here in the United States. And often that means that the networks are shut down. There's not access to the systems. And so that becomes another area of resiliency that supply chain teams need to prepare for. What happens if I can access the system? What if, what is my alternatives to make sure I place an order if my system's down for a day or two or a couple weeks? And planning those, what do I normally order every week? And can I just call up my supplier and place that order? And maybe it's not that their ERP's down. So maybe I need to have ways to get access to the ERP if I can't get access to my network. So that's a whole new area that I think is becoming a focus. And I'm not sure. I know, Eric, your team's been prepping for this. So I don't know if Eric and Ashley, if you want to add a little bit on that area of resiliency as well.
Yes, thanks, Keith. And frankly, it's scary. As you touch on this, and our organization has been planning for a downtime procedure of 1 month, so 30 days. How would we function if we could not get our core systems or components, as you touched on, of our core system acceptable? And so there's been growing efforts on planning for how would we operate, how would we do patient care, how do we do surgery if not only if our ERP is not working, if our electronic medical records not working, email. And so there is work groups that are working on all of those areas. And you find, at least I do, I find myself going down these rabbit holes. And some of them, as I said, are frankly terrifying. Like we couldn't even survive without a day or two, let alone, a week, let alone a month, in all reality. And you think about, oh yeah, we can do that. And then if you kind of get over that hump and you realize, yeah, you have redundancy, or you have these different systems, or we have these resiliency efforts in play and emergency preparedness. So it gives you a bit of reassurance. But as we started this journey a while ago, frankly, it was terrifying. But I echo your comments that it's a growing area, that it's not, a matter of if, it's when these are happening. And you've heard some really unfortunate situations of peer organizations around at least the United States that have been impacted and have been offline for days, if not weeks, and the financial impact and unfortunately patient harm that could cause.
Absolutely. We're going through that journey as well for disaster recovery and planning. And so we've looked at if it's a short-term recovery effort versus we did something similar, if it is like 30 days or longer, what our plans are, and have mapped it out in terms of if the ERP is down, if the network is down, or if both are down, how we would react to that. As part of our planning, we went through all of the reports that we have available in Workday to us and have identified a core group of reports that we did disaster recovery backups for, a couple of ways where they're mapped for different access points, so that even if our network is down, we can grab files off network. And through that, we've also been working with our distributor in terms of how we could place critical orders during the downtime, and continuing to really map out what we would do in that situation, how our teams would react, how they would perform their essential job duties. And I agree, it's not if, it is when as well in terms of our preparation.
Thank you. Question from the audience is about consistency of supplies across different clinics, saying that it is a key target for many healthcare services. So how did you manage the individual's desires to get to a consistent product choice? And start, Eric.
Yeah, I'm happy to take that first pass. It gets back to that ecosystem that I touched on. We have that led by clinicians. That's our acute hospitals that frankly drive a lot of that. And then our ambulatory or non-acute or clinics, as we call them, kind of come along for the ride, and they have a seat at the table for those discussions. But I think in full transparency, a lot of the decisions are led by our acute or hospital based counterparts or members at the table. I know there was a train of thought years ago that you could have a different product in the different setting. Like, do you need the same bandages or gauze, or you say any product in the non-acute setting, given the lower acuity or need versus a higher need, in the acute setting? We have made a decision as the organization to standardize the value of a consistent product, and the bandage that you get at a clinic versus the emergency room versus the operating room is consistent across the organization. And so that's where we've addressed it. So they have a seat at it, but they're frankly a quieter voice than what our acute hospitals are driving.
And so I'll just go into another question.
Okay.
We've only got a few minutes left, Ashley. This one's about, did you find the transition of data from many systems into the new ERP and a single repository challenging? And if so, which the questioner imagines would have been, how did you overcome this to ensure accuracy of data was captured in a way that could not be misinterpreted or changed going forward?
So in terms of this, for like our data, for like our item master and that, we were fortunate where we were transitioning from a single system, but there still were issues with the overall data that we needed to transform as part of the overall initiative. So as part of that, really it was developing a data governance structure, identifying how data should go in the system moving forward for like our item master, so that we could reach like GHX, like top 50 status in that. But also to ensure we had that quality data for transactions. So it was really using whether it was like formulas or checks against data repositories that existed with our group purchasing organization to really do checks against key data points and ensure that information was cleaned up, where we always cleaned it up in our existing system and then extracted the data as part of our load to build our production tenant for go live. And from there, it's continuing to drive those data standards to ensure anything new goes into the system. So we've instituted review processes, even for like new items that are added to the system, that it goes through an additional committee to do a review of the data to ensure we're meeting certain standards before it gets added into the system to eliminate that overall noise.
Great. Eric, if you had something very brief to say, I know you moved from multiple systems to a single, just about that data transition before we wrap up, that'd be great.
I can't overstate how critical that was. And I think I touched on it previously. Different item masters, to Ashley's point, different logins. For us to have a centralized, ERP has such been a game changer for us. And so, the ability to query data, to report, to have our dashboards and visualizations, that in itself has been worth all the effort and energy to make this move. So it's been a huge, huge benefit, and probably the single biggest value that we've been able to achieve.
Well, thank you so much. On that positive note, we are going to have to wrap it up. So thank you to our panelists for such an interesting discussion, and to our sponsor Workday, and to all of our viewers for joining us today. And thank you for supporting HINS. So if you're not already a member, you can click on the HINS logo at the top left of your screen or go to hins.org.nz. Mā te wā.